Two people, same age, same cholesterol, same blood pressure, both non-smokers, but one suffers a massive heart attack at 48 and the other is trekking in the Himalayas at 80. Why? Maybe the answer is not just cholesterol, sugar or blood pressure, but fire inside your arteries, that is invisible inflammation. High sensitivity C-Reactive Protein or hsCRP is the blood test that actually tries to measure that fire. But can it really predict heart attacks? Namaste and welcome back to HG Cardiowise. I am Dr. Ameya Amonkar and today we are decoding hsCRP, what it actually is and what the numbers mean. We will discuss in detail whether you should do this test and what on earth do you do about it if it is high. Stay with me till the very end and I'll explain with examples how it actually fits into heart attack prevention and how I use it in my practice. So let's get started. Let us start with the basics. CRP stands for C-Reactive Protein. It is a protein made by your liver when there is inflammation anywhere in the body. So infection, injury, tissue damage or chronic inflammation. Now think of CRP as your body's smoke alarm for inflammation. If you have pneumonia, dengue, arthritis flare or a bad infection, CRP can shoot up. But here's the catch, the usual CRP test is designed to pick up big fires, not the tiny ones. Now high sensitivity CRP or hsCRP is the same protein, but the test is much more sensitive. It can measure very small amounts in the blood, typically between 0.1 and 10 milligrams per liter, and that helps us pick up low grade chronic inflammation, including the inflammation within the artery walls. So in simple words, CRP is the general inflammation test. hsCRP is the zoomed in version we use to assess cardiovascular risk. Now CRP tells us if there is a big fire, hsCRP tells us if there is a slow smoldering fire that could over time weaken the arteries and contribute to heart attacks and strokes. Many of us think that heart disease is just a plumbing problem. The cholesterol accumulates in the pipe blocks and one day it closes and a heart attack. That is only a part of the story. Atherosclerosis is actually an inflammatory disease of the artery wall. Now here is what really happens. LDL cholesterol particles sneak into the wall of the artery, the immune system gets irritated and sends white blood cells. They eat up the cholesterol, become foam cells and form a fatty streak. Now over time this becomes a plaque. Now when inflammation is high, that plaque is more unstable. It has a thin fibrous cap and a soft inflamed core. It is like a pimple in the artery wall ready to burst. If the cap ruptures, the body thinks injury and forms a clot. Now that clot blocks the artery and that is your heart attack or stroke. So cholesterol loads the gun, but inflammation is what pulls the trigger. hsCRP gives us a rough idea about this underlying chronic inflammation, especially when you are otherwise stable and do not have a visible infection. Now let us get to the numbers. How do we interpret hsCRP for heart risk? See, most major groups, including the American Heart Association, use three broad categories for hsCRP when we think about cardiovascular risk. Number one, hsCRP less than 1 milligram per liter. That is considered low cardiovascular risk from an inflammation point of view. Number two, 1 to 3 milligrams per liter, that is intermediate or moderate risk. And number three, more than 3 milligrams per liter, that is high risk associated with a higher chance of future cardiovascular events. Large population studies show that compared with people who have hsCRP below 1, those with an hsCRP above 3 have roughly 30 to 60% higher risk of major cardiovascular events and death over long-term follow-up. One recent European analysis which followed people for decades found that having hsCRP 2 or above as compared with below 2 was associated with about 22% higher risk of major cardiovascular events and around 30 to 37% higher risk of cardiovascular and all-cause death. Now, important clarification here, hsCRP is a risk marker and not a prophecy. A high hsCRP does not mean you will definitely get a heart attack. It means on average in large groups of people, those with high hsCRP tend to have more events. And a lower hsCRP does not mean you are invincible. It just means inflammation related risk looks low right now. Okay, next question. How do we measure hsCRP correctly so that we do not overreact or underreact? First, it must be a high sensitivity assay. Just CRP on the form is not enough if you are using it for heart risk assessment. The lab report should specifically say hsCRP or high sensitivity C-Reactive Protein. Second, timing is critical. If you have fever, cough, sore throat, a tummy bug, a flare of autoimmune disease, recent surgery or injury, hsCRP can go up dramatically. So, if you just had a viral fever and your hsCRP is high, don't WhatsApp your cardiologist at 2 a.m. Just repeat it after you are feeling well. Third, variability. See, hsCRP can bounce around a bit from day to day. For cardiovascular risk, many experts recommend measuring it twice, about 2 weeks apart, in a stable, infection-free state and taking the average. Now, that helps smooth out random fluctuations. Fourth is lab differences. See, different labs may quote slightly different reference ranges. But for cardiovascular risk, those three categories, that is less than 1, 1 to 3 and about 3 milligrams per liter, are widely used across guidelines. An important practical tip: if your hsCRP comes back between 3 and 10, but you recently had an infection, it is very reasonable to repeat it after a couple of weeks to make sure that it was not just a temporary spike. Now the hopeful part: if your hsCRP is high, can you bring it down? Yes. And the good news is that the same habits and medicines that reduce heart attacks also tend to lower hsCRP. Now let us start with lifestyle. First is weight loss. See, fat tissue produces inflammatory cytokines, and several trials show that losing 5 to 10% of your body weight through diet and physical activity can reduce hsCRP by roughly 15 to 40%, especially in people who are overweight. Second, exercise. So regular structured exercise, both aerobic and resistance training, is powerful. Meta-analysis show that exercise-based interventions can reduce hsCRP in the range of about 10% at a few months to even 30 to 40% with longer programs, particularly when combined with weight loss. Third, diet. An anti-inflammatory eating pattern, that is more fruits, vegetables, whole grains, legumes, nuts and healthy fats like olive oil, mustard oil, fatty fish and a few refined carbohydrates, sugary drinks, processed meats and trans fat is associated with lower CRP levels. Fourth, smoking. See, smoking is like adding petrol to the fire. It increases systemic inflammation and hsCRP. So, stopping smoking over time reduces CRP and dramatically drops cardiovascular risk. Fifth, sleep and stress management. We know chronic sleep deprivation and stress without recovery increases inflammation. And finally, medications. Statins, the cholesterol lowering drugs which many of you know, also have anti-inflammatory effects. They reduce hsCRP independently of how much they lower LDL. Now, in the famous Jupiter trial, that is the landmark study which changed preventive cardiology, they looked at people with LDL cholesterol less than 130 mg/%, but hsCRP 2 or more. Your rosuvastatin 20 milligrams daily reduced major cardiovascular events by around 44% and lowered hsCRP by around 37% compared to placebo. So, in that study, treating an apparently normal cholesterol person with elevated hsCRP significantly cut heart attack risk, strokes and cardiovascular deaths. Now, this does not mean hsCRP causes heart attack, it means inflammation plays a role in the risk. Other targeted anti-inflammatory therapies also have shown benefits in selected high-risk groups, but those are not for routine use and they have their own risk and cost. So, for most people, the foundation remains lifestyle plus, when appropriate, statins and other standard preventive medications. So, now the practical question: should everyone watching this video run to the lab tomorrow morning for hsCRP? Not necessarily. See, current guidelines treat hsCRP as a risk enhancing factor and not a universal screening test for everyone. So, where is it most useful? In people with borderline or intermediate 10-year cardiovascular risk, where you and your doctor are not very sure about starting a statin or stepping up prevention. Now, if your overall risk is very low, you're young, no major risk factors, hsCRP usually does not change management. If your risk is clearly high, for example, you already have a heart disease or you have diabetes with multiple risk factors, you anyway need aggressive risk factor control. In that situation, even if hsCRP is low, treatment does not go away. So, hsCRP is the most informative in the grey zone. So, when Traditional risk factors do not clearly say yes, treat or no, you are fine. In that zone, a high hsCRP can push us to be more aggressive with statins and lifestyle. A low hsCRP might support a more conservative approach depending on the full picture. And just to stress this, hsCRP is just one piece of the puzzle. We still look carefully at blood pressure, LDL, HDL, triglycerides, blood sugar, family history, smoking, physical activity and diet. No single blood test should be the judge, jury and executioner. And of course, this video is for education purposes. Please do not start or stop any medication based only on what you hear here. Always talk to your own doctor who knows your case in detail. Now let us finally answer the big dramatic question. Can hsCRP predict heart attacks? At a population level, yes. Higher hsCRP is consistently associated with higher rates of heart attacks, strokes and deaths, even after adjusting for cholesterol and other risk factors. But at an individual level, it is more nuanced. No test can say you will have a heart attack next Tuesday at 5:43 p.m. hsCRP improves our risk estimation, but it is not perfect and it is not destiny. Think of hsCRP like a weather forecast. A high hsCRP is like a forecast saying there is a higher chance of storms in your city this month. It does not guarantee rain tomorrow, but you would be smart enough to carry an umbrella, right? In our world, that umbrella is lifestyle change and where appropriate, medications like statins. A very low hsCRP is like a sunny forecast. Nice to see, but it does not give you a license to smoke, eat junk, ignore your blood pressure or skip your diabetes medications. Cholesterol, blood pressure and sugar can still do that damage quietly even if hsCRP is behaving itself. So, hsCRP is a helpful tool, not a crystal ball. It tells us about chronic inflammation. We use it to fine tune risk, particularly in that borderline group and to motivate lifestyle and preventive therapy. Before we close, let me show you how I actually use hsCRP in my practice. I think of it as one more piece of information that can push us slightly towards or slightly away from starting a statin in borderline cases. An hsCRP of 2 or above is considered a risk enhancing factor, especially if the 10-year risk is borderline or intermediate. Now, let me give you two real life examples. Rajesh is 46, he does desk work, not very active, slightly overweight but not obese. His LDL is borderline around 120 to 130 mg/%. Blood pressure is okay, fasting sugar is okay. If you put these numbers into a standard 10-year risk calculator, he lands in that borderline to low intermediate risk zone. So now the important twist, his father had a heart attack at 52. So here is a strong family history of premature heart disease. Now we decided to check his hsCRP. We did it when he was well, no infection and we repeated it to be sure. Both times his values were above 2. So here is how I think about him. Borderline LDL, positive family history, hsCRP above 2. In this scenario, I lean towards starting a preventive statin along with strong lifestyle changes rather than just saying let us ignore it and hope for the best. I explained to him that the absolute risk is not sky high but clearly not negligible, and that lowering LDL and probably reducing inflammation gives him a better long-term chance. Rekha is 50, she walks 8,000 to 10,000 steps a day, eats reasonably healthy, does not smoke and her weight is in the normal range. Her LDL is again borderline 120 to 130, BP is normal, sugars are normal, her 10-year risk also falls into that same borderline zone. Unlike the previous patient, there is no strong family history of premature heart disease here. We check her hsCRP twice, again in a stable state and both readings are low, around 0.6 to 0.8 milligrams per liter. Because she really wants to understand the risk, we also did a coronary calcium score. The result came back as 0, meaning no visible calcified plaque in the coronary arteries, which is associated with a very low near-term risk of cardiovascular events. So now look at her. Borderline LDL, no strong family history, hsCRP low, less than 1, calcium score 0, excellent lifestyle. In her case, I am very comfortable focusing on lifestyle and close follow-up, and we did not start a statin immediately. This does not mean we ignore cholesterol forever, it means we individualize. Her current risk signal is reassuring, so we give lifestyle a chance and recheck after a few years or sooner if anything changes. So I don't use hsCRP in isolation Along with the traditional parameters, inflammation adds nuance. It helps us personalize the decision rather than treating every borderline cholesterol value exactly the same way. Bottom line, hsCRP is a helpful tool and not a standalone judge. Always interpret it with your doctor in the context of your full risk profile. Now, if you found this video helpful, hit like, subscribe to HG Cardiowise and share it with that one friend who is worried about having a heart attack. Now, tell us in the comments, have you heard about hsCRP before today and what topic we should decode next. Stay heart smart, stay calm. I am Dr. Ameya Amonkar from HG Cardiowise and I'll see you in the next one.